what we're talking about here is sort of combining these two and whether or not, well, maybe we want to use both of these, and can I do a better job instead of just being a baby of one, right? And we're way beyond, doing clinical studies just looking at one intervention. Our statistics are much better. So we're able to kind of tease these things out. So I mentioned this earlier, parallel versus series. And so parallel means that we're using them together, right? Within the same treatment session, essentially, or within the same instigation of management. So what we're able to accomplish with that is photobiomodulation seems to be super good at what we call it priming. Um, Not really a technical or medical term, but by priming and setting that stage for basically a potentially more aggressive therapy. Now, if you've been doing this long enough, you've heard studies, and I showed tons of studies showing, when you're trying to accomplish the same physiological process with two different approaches, it doesn't tend to typically work. This is where this is the most unusual aspect, because we also used to say that you couldn't facilitate an accelerated, process with regards to the normal physiological process of our patients. Like, these are the first two therapies that have actually been shown to do that. In other words, applying this to a very healthy person seems to accelerate healing even more so. We used to always talk about just really creating the optimal environment with regards to healing. So when we start off by priming and increasing that metabolic activity, and you can think about, you know, where is this really important, and who could potentially benefit from the most? Think about those really chronic people that have this acute exacerbation that come in here. So really what we're trying to do is optimize these biological pathways. And there is some slight differences between the two, although there is going to be obviously some overlap. And here's the thing, there's not a lot of studies looking at these from this parallel perspective, right? This one is constantly quoted in plantar fasciitis, and it's okay. The cool thing is that whether you're doing photobiomodulation, shockwave, or combined, they all benefit from a statistically significant opportunity. Now, this one study actually showed that when you combine these two, you get further benefit from the combination of these two things versus just doing photobiomodulation or just doing shockwave. Unfortunately, we haven't seen a ton more of this, and I'll talk about some other things here in a second. But I think what's important here is, if you look at the methodology that's being used, it's also important to look at the progressive nature of some of the research studies that are being done, right? This is classic, like, stuff that was done in exercise therapy, 20, 30, 40, 50 years ago, where, they got stronger initially, but they didn't change anything. So from the midpoint to the end point, they weren't any better, right? All of that took place at the beginning. So it's real important to look at it from the perspective of actually being more progressive. I think what's also unique about plantar fasciitis is we've got this kind of overlap slash, competition between shockwave and radio pressure wave. And it seems to go back to really that inflammatory response. And that's my prediction of why that study turned out the way that it did, because it was really addressing really those two kinds of mechanisms here. So this is a study looking at myofascial pain, in particular, trigger points. Trigger points in the upper trapezius are always, I don't know, interesting, and I think they're tough to study because they never completely go away. I always used to tell my students, get really good at the upper trapezius, and you'll have patients for life, because as soon as you become adults, they're all there and they never completely go away. We suppress them, and then eventually they come back. But what they found was the combined effect versus the individual effects wasn't any different. They were both good, right? So looking at the benefit of laser, looking at the benefit of shockwave and the combined effects, they were all good. We saw it was not significant, but we did see an improvement over the combined effects. So what about the methodology? Well, the methodology is challenging because, again, it wasn't overly progressive. I think there were some antiquated approaches, especially from their laser perspective, using lower powers and things like that. But overall a pretty good and comprehensive study. This actually comes from a thesis, so as you can imagine, a lot of work was done in this. Systematic reviews. You always got to be careful with these. Are they always giving you, you need to decide if the criteria that they're using to include their methodologies is aligned with whatever it is that you're doing, your techniques, your patients, and so on. So 28 RCTs looking at laser versus, so these are not combined effects. So really looking at the whole, myriad of neuromusculoskeletal pathologies that most of us are actually going to see in practice. Now, what's different about this is they also did this comparison with the low level and the high, and so we're seeing more and more literature come out with high intensity laser therapy, which is good because we used to think that it didn't matter about the power and it was more about the wavelength. Well, with these higher powers, we can actually drive longer wavelengths, and that's kind of changing the game a little bit as well. So basically, what it's saying is not much difference between the two, and even comparatively. But again, you need to look at their studies. But again, the good news is the research is there supporting the efficacy with regards to either one of these, and it's really going to be kind of up to us to look at the potential future of what we can accomplish as a result of doing more studies. But I want to plant this seed and I want you to think about whatever it is that you do in practice, right? And it includes your practice management, it includes your patients, it includes even the people that you work with or employ, or if you are one of those clinicians that have been doing this maybe as long as I have, and what, you know, gets you fired up to go into the clinic every day. So the implications are they certainly can be, and some studies do support that notion. The significance, I think, is going to come a little bit more from doing a really good job at choosing those patients, likely, especially if you're dealing with a very inflammatory nature in combination with a more recalcitrant type of condition. Um, and I especially think in those people that have had these really long cases. A lot of people are going to say, "Well, I get really good results." We all get really good results in the acute phases. The challenge is, what can we do if we're getting those more recalcitrant? And what does your data actually look like? So if I can I compare, those differences within my own clinic as to whether those results could or would have been better? So we do have the evidence that supports that. Consider combining, for those more potentially complex. And some of it not only includes the complexity with regards to the recalcitrant nature of the condition, but also from the psychological aspect of those patients. Remember, once you get past about 3 months and we're looking at those people that score poorly on like a FABQ, a fear avoidance belief, that their likelihood of getting better is, they're kind of on that downside. The cool thing is, if you think about it, it does align really, really well if you're looking deep into the biological process, like some of us might with regards to what's going on. What's my take? um, it's this is where the art of clinical application comes into play, in my opinion. In the foot, plantar fasciitis, it's almost a no-brainer for me, and that's typically just my automatic go-to. Other areas of the body, spine is kind of another one. Most people come in with chronic low back pain that have had these problems for years, but they come into us because of an acute exacerbation. So I want to deal with that and then kind of move to that next level. And I'm going to talk about this in a second. Otherwise, if I'm going to be very aggressive, so here's the thing. Sometimes I work with people that are very transient. In other words, we need to get them back to work or to play. I get a lot of people that come here for vacation. And so I just need to, get through 2 more weeks. I hurt myself water skiing. I've never been water skiing before, or we're in season. What can I do, to facilitate the greatest amount of recovery that I possibly can? And again, that combined with potentially being very aggressive with some of my other therapies seem to be really, really beneficial. And if we look at, there's some really cool studies looking at the benefit of recovery from both of these types of applications with regards to high intense bouts of training in, the athletic population. Here's the series rationale. This is where we go, okay, I'm going to do a course of laser, then I'm going to do a course of shockwave. And this is where a lot of us probably started before, maybe combining the two. And we've got a little bit more literature to really support that notion. And again, it goes from a biological plausibility perspective where it makes sense. Photobiomodulation works super awesome, especially during those early acute stages, right? Um, Very non-invasive, comfortable for patients. And this is where I start to get into, well, think about your practice type or your patients. If you're dealing with older adult patients, sometimes this is a great introduction to you, your clinic, your approach, because the likelihood of making someone feel uncomfortable is unlikely. Now, if you're especially on you do a lot of like physical work, most of those people come in anticipating that they should feel a little bit better when they leave than when they came in. So, do we really want to do something that might be on the uncomfortable side? I didn't say bad for them, but uncomfortable, because shockwave can be that. It's expected, in fact. Um, Not always. I'll come back to that in a second, but if you're trying to develop that level of rapport, people that are very, very sensitive as well, photobiomodulation tends to work really, really well. Shockwave, especially in those chronic cases. Now, when someone comes into the clinic, and again, most of the people actually come into us because they're in an acute stage of a chronic condition, if they're coming in for a chronic condition, or I used to spend a lot of time on the sideline as a previous athletic trainer, so I treated a lot of really acute conditions as well. But when we're dealing with the outpatient clinic, a lot of those people are coming in and entering the system as a result of a chronic condition with this acute exacerbation. So again, they kind of have both of these things going on. So that's where, if we're dealing with those earlier phases, and I think I might have a point on this later, but I'm gonna chase to that. And so statistics show that, when our patients come in and we ask them, why are you here today? And they say, I have low back pain. Well, that's what they have, but why are you here? Inevitably, what they're explaining to us is, when I say, how long have you had low back pain? About 3 years. Just getting around to it now. So, in other words, they've been in pain. They can live with pain. The problem is when they get to a certain level of dysfunction. In other words, the disability is really what brings patients in, statistically speaking. In other words, they say, I came in for shoulder pain, back pain, knee pain, whatever the case may be. The problem is their pain has gotten to a level at which it's keeping them from doing certain things that they value. It could be either work, riding their bike, running, exercising, bending down to pick up their grandchildren. All of those things are associated with disabilities that have been taken away from them. And that's the real reason that the majority of the patients actually enter the clinic and come in. And so now, that doesn't mean that statistically speaking, we ignore pain, but the problem is if we're hyper focused on pain, and WebPT did a great job at collecting some of this data, but if you're in the outpatient physical therapy clinic, 30% of your patients are completing your course of care. Maybe you're better, but overall as a profession. So 70% are leaving earlier. 48% are discharging themselves within the first 3 visits. Well, that's actually a testament, because we're pretty good at getting people out of pain. That's not the hard part. The hard part is getting them back to that level of function. And that's where, we need to think a little bit about what it is our approach is going to be. Um, One of my favorite shows, King of Queens, Doug Heffernan, chronic low back pain, right? As you can imagine, not the healthiest of lifestyle. So when we look at this biological synergy, let's say Doug came in to see me, he's in that acute exacerbation. And a lot of that pain is actually being generated from the inflammatory response, which again, we just described as photobiomodulation being really important at that. And then once we've managed that, and they may be good to go, and that's why 70% are going to leave, right? If you're in that outpatient physical therapy space. So, how do we keep them? Well, we need to talk more about performance. And this is where we don't shift gears. Like, this should take place in the review of findings to say, I get it, you're in pain, but here's why, right? And we go back to talking about this functional based outcomes, in that okay, we probably need to measure that, right? I use gait analysis, strength, range of motion, the whole gamut. So what can we do? And that's where that discussion takes its turn. And it's like, okay, let's get you out of pain first. And that's going to actually allow us to do those other things that are going to be necessary to facilitate a better opportunity with regards to healing and improving that overall function and minimizing the frequency that this is actually going to come back and turning into something that's going to be potentially more problematic. Okay. So just quickly, so there are studies that go through this process where it initiated with photobiomodulation and then was followed up with extracorporeal shockwave. I didn't put my references in here. I think they're at the end. But so plantar fasciitis is one of those. And that's what's interesting is, well, that's what I found in practice, even before, finding a study like that that could actually support that notion. And it's actually the same thing in rotator cuff. And we also see the same thing in Achilles tendinopathy. So these are just the areas where we've seen that in terms of some of the research that's actually been done. Hopefully, we're going to find more with regards to, the studies that are coming out. I can tell you in clinical practice, low back pain is inevitably another one. I always find when I do medial and lateral epicondylopathies are super interesting because people can focus on them and they really know the difference when something actually changes, which is pretty awesome. And inevitably, I just have people when we transition, it clicks to them, and it in their mind, it's really important because it's very motivating with regards to the compliance and adherence, right? And that's pretty cool because one, it keeps them coming for all of their treatments, but two, it gets them more involved. Like they're more likely to stay within their lane with regards to the things that we're telling them to do at home. So it's part of your clinical framework. So during the acute stages, and when I say acute, I mean literally acute, the stages of injury and healing, not pain, right? Acute pain versus chronic pain, that's a different metric than we look at the actual physiological profile with regards to inflammatory markers, right? So, and here's a thought process if you're not already doing that. By the way, you should let your community know that you can deal with these acute conditions. And some of us are pretty good at that. Some of us, well, maybe you've got a full schedule and you don't need to be doing that. But again, 3 to 5 times a week. So what happens is we tend to load. So imagine if you're looking at from a volume perspective and do the numbers. This is important too to figure out what should I implement, why should I implement something? But let's say if I do this 3 times a week on patients that come in, because we tend to front load, right, for multiple reasons. But if I do this 3 times a week and that's 6 visits, that yes, maybe that's the one thing that's not being covered by insurance. That's going to be an out of pocket expense, which by the way, people are actually okay with, even Medicare and Medicaid patients. But I'll let you guys think about that for a second, right? And then we get into the subacute stage where we might continue with a couple more visits. I don't think I ever really tend to go over 8 if I'm doing this more series, because if you've done your job, then really you're beyond that subacute stage, and you're dealing with that chronic condition, which is the ultimate reason why they actually came in. So the cool thing is with Shockwave, it's only 1 time a week. So that matches up with that change in frequency. And by the way, if you're thinking about patient perspective and their interpretation of what's actually going on, they see that reduction as progression. What do you mean I don't have to come in as much? Well, you're doing better. More things are going to be done to you at home. More specialized care is going to be done here, and it doesn't require as many visits. So that patient psychology is really important because in their mind, that actually shows progression. And inevitably, and I was alluding to this earlier, which is let the healing begin. I've literally had people say that when we make that transition, and it kicks it up a notch. The other cool thing about this particular process is if they were a new patient, kind of timid, all things done that were pretty comfortable, and then we move into the things that might be a little more uncomfortable. And again, the patient psychology from that perspective is like, well, this guy knows what he's doing because he's made me feel better. And then, wow, that was a little uncomfortable, but look at my range of motion. Look at my decrease in pain and whatnot. So this particular process builds a lot of confidence in the patient, and it also provides a super duper experience. I, there's others. I like stop pain clinical. So if you're doing radio pressure wave uses a medium because it's acoustic, right? So you use ultrasound gel. I use a topical as well. And the reason for that is by the time the topical actually is absorbed in doing some of its work, I've gotten through the initial stage of sort of that discomfort. But what it does is it dramatically influences and creates a more positive experience for the patient. It makes the experience more comfortable. It actually allows me to be a little bit more aggressive if I need to do that from that more stage approach of getting to that tissue, either with energy or depth of penetration. And I always do this, comparing and contrasting care versus treatment, right? So treatment is very sort of focused on the here and now, the symptomatology versus a care plan. So studies are being very clear and showing us that patients are very interested. If you show me the whole ball of wax, they're much more likely to say, "Oh, I don't mind paying for something that's going to be out of pocket." And I don't think I even said this at the beginning, but photobiomodulation and shockwave are typically not covered. You may find this in workers' compensation and PIP, but in general, not typically covered. So it is going to be that out of pocket expense. So when care plans are actually developed and we outline this, and I actually have an algorithm that I've developed that shows and it lays it all out so they know exactly what my responsibility is, exactly what their responsibility is. So really important to talk about these things because in the review of findings, if you're so hyper focused on pain, you're going to be one of those statistics that they're going to leave, those 70%. If you're a two clinic physical therapy clinic, that could be as much as $250,000 you're leaving on the table, especially if you're not just dealing with, elective referrals into the clinic. So the integration, I mean, integration and implementation are always our challenge. Like, how do we do something new? There's a lot of programs out there that help us understand what exactly it is, where it fits. I've been talking about this kind of stuff for a long time. The time frame in the application is not extensive. So with photobiomodulation, it can be just several minutes. It can even be unattended. Um, Now, remember, unattended doesn't mean unsupervised. So I still want to be in earshot, but that allows me to go do something else. And then, even with Shockwave, the typical treatment range is between 5 and 8 minutes on the long side. And I think I have a slide where I talk about something about that in a second. But um, so the integration, it adds a couple more minutes, but because it's not a covered therapy in general, it's not actually taking away from your maximal code utilization, for example. And in fact, if you're using the radio pressure wave to go over the pathological site to get deep penetration and then using your ISTIM, you're still your 97140. You can still build these other soft tissue codes in addition. The other cool thing is it allows us to think out of the box. And so dealing with some of these other conditions that I think are a little bit more challenging for some of us practitioners um, from a non-pharmaceutical perspective, for example. Coordination, and this is, I've been fortunate to work in many different facilities and work with different facilities where we have this more sort of integrative approach with physical therapists, athletic trainers, chiropractors, strength and conditioning coaches, and things like that, because it really allows us to also bring and tie in some of those assistants that can do these because they're not specialized. It really 85 to 90% of the time, where do you do it? You do it over the boo-boo. So it's not like teaching soft tissue application techniques. So we typically teach, what are the benefits? What can we get from it? And then I love talking about the transition. Here's where we do this. Here's where we do this. And it's a range. I mean, it's not the exact same between every single person. But what it does is it really outlines a complete course of care with stuff that people can actually feel and arguably is going to be measurable. So the implementation, again, there's the series and then there's the parallel. Sometimes it's better to start with one or the other. So if you're already working with one application, Now you can kind of see, well, where would I do the other one? And basically within series is going to be the easiest part of that implementation. Collect your data, look at, well, how do they feel about that? The cool thing is that either one of these doesn't add a lot of out-of-pocket expense. Think about if you're doing laser now and you want to add Shockwave, 3 to 6 visits, at the nominal fee that you're charging. And the cool thing is that again, patients don't really have problems paying for things that seem to work. Um, in conclusion, there's my pickleball pitch again, but think about that for a second. So photobiomodulation works great at priming. Again, early stage, especially in that series, I think works awesome. The phases align not only physiologically, but also psychologically. I would really tie this into what the patient progression is going to look at and look like so they have an understanding, and then really think about, do some research on what today's practice looks like, things that people are looking for. At the end of the day, I get it. They're patients. We're all in healthcare. And, when I used to talk to students about billing and coding, oh, Dr. Prue, we just want to help people. And I'm like, well, the reality is that people have choices of where they can go. Um, Insurance doesn't cover anything, everything, anything, everything. And that's another discussion in and of itself of why they probably never will, which has its pros and cons, but also modernizing your practice. We're seeing a lot of dropout, a lot of attrition in the professions. I mean, people are potentially getting bored. Straight up billing and coding, depending on the type of practice, it's pretty challenging, to accomplish that. But again, it's not about money, but just think about what patients are actually looking for, and how that can be implemented within your practice setting.